Many patients make the mistake of not doing an endoscopy or a colonoscopy when they're advised because they're afraid of undergoing it because it's uncomfortable. And that's one of the major reasons why we miss in our country picking up early tumors.
Do you think that IBS, one of the main causes is anxiety and stress?
Absolutely. Popping a pill for abdominal pain and gas is so common that we have far more deaths due to abdominal emergencies now than anything else. In patients with obesity nowadays, we can collect the stool of a patient with who is normal body weight and convert it into a capsule and give it to patients who are obese. When they swallow it, it can change their flora and they can lose body weight.
Dr. Sarfaraz Baig, thank you so much for coming and welcome to Infinite Health.
Thank you, Anant. Thank you for calling me.
But I'm very excited to have this podcast session with you, specifically because, I've been doing clinical research for the last 14 years. But suddenly, the gut microbiome and gut health has exploded completely exploded. But before I even start this podcast, I have to ask, what does a gastroenterologist mean?
Okay, that's a fantastic question. Because a gastroenterologist is misinterpreted as somebody who deals with gas. That's a lot of gas. The important thing is to remember that 60% of patients who walk into any healthcare facility have a gut problem. So those 60%, whoever they reach to, is a gastroenterologist. So a gut health would be having problems with esophagus, stomach, gallbladder, liver, pancreas, intestines, colon, rectum, anus. So you see, it's a lot of things. So any healthcare provider who is dealing with one of these or all of these organs of your body, they are gastroenterologists. So that is what a gastroenterologist means. Of course, they will be coming with various problems, starting from heartburn, reflux, to difficulty in swallowing, to not able to eat, nausea, vomiting, jaundice, bloating, constipation, diarrhea, bleeding in stools. So there could be so many plethora of symptoms, and these will all go to the gastroenterologist. So that's what a gastroenterologist is. Anant.
So basically anything that enters our mouth and goes out of our anus, everything in between is your...
and
sort of comes under your domain.
True, and some more like liver, pancreas, who are
where all the metabolism happens.
Yeah, a lot of enzymatic things happen from there. So those are also incorporated into gastroenterology. In fact, nowadays we call it luminal gastroenterology and solid organ gastroenterology. Solid organ is liver and pancreas, whereas luminal is, as you mentioned, oral cavity, esophagus, stomach, duodenum, intestine, colon, rectum, anus, because these are all luminal organs, right?
So I just wanted to break this down for the audience. Like if I had to put it in a very simple manner, like once we eat, it goes through a food pipe to our stomach. From our stomach, that food goes to the small intestine. From the small intestine, does it directly go to the large intestine?
Yeah, that's right.
And then
to the rectum,
then to the rectum, and then through the anus and out.
Absolutely.
While at the same time, the liver is metabolizing the food that we're eating.
So I would interrupt you. They're not metabolizing. Liver is the place from where bile is secreted, which is aiding in digestion of fat. That's one of the functions of the liver. Similarly, pancreas is secreting enzymes, which is going to digest protein, fat, and carbohydrate. So all of these. So I'm not saying that liver and pancreas do not have other functions, but as far as digestion is concerned, they contribute in this manner.
Because something that I really want to understand is that, you're a super specialty doctor, right? But gastroenterology or these problems that we just mentioned is something that every single patient will have at some point in his life. Like we keep talking about how we should visit dentist once a year, how we should visit a dermatologist or a skin doctor once a year. But I have never seen such a protocol for a gastroenterologist, because usually people would go to a general physician.
So I think, Anant, it is fair. When you have a problem which is so ubiquitous, so frequent, when I said 60% of patients who walk into a hospital have a gastro illness. Similarly, imagine in our own houses, when somebody complains, they usually complain of what? Gas, digestion issues, somebody's got a diarrhea, somebody's got constipation. These are very common problems. And these problems, if everybody is going to go to a specialist, I think the specialist is not needed, number one. And number two, they will be overloaded with this problem.
Right.
I think it's fair for patients to first reach out to their physicians, who would be definitely able to control most of these innocuous symptoms. Only when there are 10% of these symptoms which come with warning signals. So please do ask me, what are warning signals? These warning symptoms are the ones that should be referred to the gastroenterologist.
Right.
So not all of these symptoms should be carried on to the gastroenterologist. Only after it is screened by the general physician, then it should reach the gastroenterologist.
So what are the warning symptoms that would lead a person to a gastroenterologist?
Absolutely. So now see, if somebody says that I have got a heartburn and reflux, so I am getting a heartburn and a reflux, that's fine. A lot of people have it. They go to the family physician, they get some dose of a omeprazole or any other prazoles, and they're better. But let's say it's not working. Or let's say even after taking the medicine, when they stop, it's coming back. Now that's a warning signal. Get to a gastroenterologist. One can be having a hiatus hernia. Similarly, let's go to another segment of the bowel. Let's say somebody is having an epigastric pain, which is okay. The physician can manage. But let's say they also have an associated weight loss. Now, weight loss is a warning symptom.
So epigastric pain is like pain
upper
in
abdomen.
Upper abdomen. Okay.
Yes. So now, as soon as you get that, this patient should be referred to the gastroenterologist or a gastrosurgeon. Again, let's say somebody's been bleeding in their stools. And that's fine. A lot of people bleed in the stools. They have piles and they carry on their medication sometimes in different disciplines. But if the blood is not only red, but it is also dark, and it is mixed with the stool, or if it is also associated with weight loss, and there's a crampy abdominal pain or there's distension of abdomen, these are warning signals. These patients could be having sinister diseases like inflammatory bowel disease or cancer. Therefore, these patients should be referred for colonoscopy. Now, so I may have been able to make you understand that although these symptoms per se, 90% of them are okay and they can be treated by the physician, but when they come with associated warning symptoms and signals, they should be referred. Many patients make the mistake of not doing an endoscopy or a colonoscopy when they're advised, because they're afraid of undergoing it because it's uncomfortable. So now, if I ask 10 people in the street, you need an endoscopy, and it's a pipe going down your throat, we will of course make your throat numb with something as a spray. I'm telling you, 9 out of 10 will say, no, not interested. Okay. And that's one of the major reasons why we miss in our country picking up early tumors.
But sir, I'm just sorry I'm interrupting, but I have to tell you, sir, I got an endoscopy done and they did spray something inside, but I was gagging, and that made me a little, it made me fear endoscopy,
so
to be honest.
If I told you that you have to need an endoscopy, would you do it?
I mean, I'm a health maniac. I'm a health maniac, honestly. So I will not put myself in the same range as other people. But I would probably do it. But I think in general,
people will not do it.
People would be very scared, because the pipe is going through your stomach.
So that's the thing. When we opened our clinic about a year and a half back, the first thing that I decided was to make endoscopy and colonoscopy absolutely comfortable for the patient. Which means what? Which means the patient should not know. If you were to subject a patient to surgery, would the patient know about surgery? No, they would not, because they're anesthetized. Similarly, endoscopies and colonoscopy should be done under intravenous anesthesia. And it takes only about 2 to 3 minutes. So for endoscopy, or for a colonoscopy, it will take about 10 to 15 minutes. So during that time, if you can keep the patient comfortable with intravenous anesthesia so that they have no recollection of what happened and they have no idea about a pipe going down their throat or their anus, I think it will improve the compliance of the patients for getting these done. And remember, many of these diseases require not one endoscopy or colonoscopy. They will require serial and multiple endoscopies and colonoscopies. So if somebody had ulcer You think just one endoscopy is enough? No, you would like to confirm that the ulcer is gone. Let's say somebody had a gastric polyp. Would one endoscopy be enough? No, you would need to do multiple endoscopies to be sure that the polyps are not coming in different places.
Right.
Same for colon. If somebody's got inflammatory bowel disease, at least once in a year, you need a colonoscopy.
Right.
Similarly, for tumors, we have the same thing. So it's very important to make endoscopy and colonoscopy comfortable. And one has to understand and realize that if they have been advised, please do it. Many patients would be benefited if they can just say yes to the endoscopy and colonoscopy if they're advised.
So basically, as I understand it from endoscopy and colonoscopy is like, just for the layman, like endoscopy is when you put a camera inside your throat and it goes up to your stomach and intestine.
Correct. So it's a tube. At the tip of the tube, there is a camera. And that camera is going to pick up the images. So I'm able to see the esophagus and the stomach while I'm going in up to the duodenum, right? And I can see it in the television monitor. And if I needed to do some biopsies or take out a polyp, there are channels in the tube through which I can pass wires. And at the tip of those wires are instruments through which I can take biopsies, excise a polyp. So it's really a great tool to have for any gastroenterologist.
And the same thing is for colonoscopy.
Same
like if
thing
you
is
put
for
it up, like you just go through the rectum and the large intestine.
Absolutely same principle.
Because I was just wondering, like, this is the way we do diagnosis, right? I mean, and do you feel like there is a specific age after which you should do it every year, irrespective? Because I know in the US, it's a protocol that after the age of 40, you have to compulsorily screen for endoscopy and colonoscopy once a year.
So yes, Anant, in developed nations where economics is not a problem and health is a public sector concern as well, the government can introduce a cancer screening policy. So in Japan, as you know, stomach cancer is a very big problem. Similarly, in the West, colon cancer is a big problem. So in Japan, typically after the age of 40, all men would be subjected to a routine gastroscopy. And that is how they pick up the stomach cancers early. And that's how they have a great result and outcome because they picked it up early. Similarly, for colon cancers, if the country has a high load of colon cancer and they introduce colonoscopic screening, some countries will also have stool for occult blood, and that is positive. Then they take it for colonoscopy. These screening tools are it's a national policy. And once that is done, then these cancers can be picked up early. And therefore, their treatment would be their treatment would
we can
be better.
treat them at stage 1 instead of going to stage 4.
That's the best way of putting it.
So, but I really want to bring this conversation down to like very basic questions that like a lot of us don't have an answer to, and there's a lot of confusion out there. Okay. And the first thing that I want to bring your attention to is like just the very simple concept of excessive gas.
Okay. Right.
So like, because, I know this will sound very silly because my honest question to you is like, is smelly gas dangerous for you or is it bad for your health?
So let's first break up the gas, okay? As a gastroenterologist, when people come to me, they say gas, but they mean a lot of things, right? So you may have heard about that aphorism that what you say and what you mean is not always the same. So when people say, I've got gas, I really have to ask them, what do you mean? So sometimes they'll say, I get a headache when I eat. Well, that's not gas. Or they will say, I get cramps in my abdomen when I take oily food. Could be gas. Sometimes they'll say, I get a heavy feeling in my chest. Well, that's not gas. So what does the gas mean? I think that word has been distorted so many times that it has lost its significance to the gastroenterologist. So what I am more concerned about when somebody says I've got gas is I try to dissect it and find out what it is. Now, let me tell you what it generally would mean and what I am bothered about. If somebody says that I get bloating, I feel full when I eat, and they say, yes, okay, that means the food is not inadequately digested and it is leading to gas bubbles which are getting trapped. Typically, these patients would say, the pain is not in specific area in my tummy. It migrates. Sometimes it's on the left, sometimes on the right, sometimes the top, sometimes the bottom. That's the typical indigestion and the gas that you and I are interested in. The other gas that we are interested in is when you have flatus. wind. Somebody is passing a lot of wind. Now, if somebody is passing a lot of wind through their anus, and it's very uncomfortable for them, then we need to know what are the problems that the patient can have. It could be simple. It could be a person who has been passing wind right from early childhood. Now, I'm not very bothered about that. But somebody who's started doing it in recent times, that's a matter of concern.
So if someone is doing passing gas from childhood, it's not like you don't have to bother too much about it.
No, we don't bother too much about it. This is usually somebody who has a motility like that. Somebody may be having intolerance to, let's say, wheat. Gluten, as you know, it's very common. So somebody is intolerant to milk and roti, but they have been consuming it since childhood, and they get bloating and they pass wind. Now, I could find out and tell them that this is the problem, or I could just let them be. Many times there are patients who have been having it for donkey years. Who wants to interfere in these patients? Yeah, if somebody does get very uncomfortable with this, then we would intervene, find out, evaluate, investigate, confirm, and then eliminate these food products from their body.
So motility is basically when, like, the physical way in your digestive system is moving.
So motility is simply the movement of the gut. It should be synchronous. It should be in order. If it is not synchronous, if things are not in tandem, and if the things are happening haphazardly, so let's say the proximal segment is contracting, the segment in front should relax, but both are contracting.
Right, it has to like pass on food like in a normal direction.
Absolutely.
So if someone has been farting since he was young,
then
it's just the way their motility is.
This is the way their motility is. They probably have some food problems, and that can be investigated, but largely we leave them alone.
So what if the fart is smelly? Then does that mean that there's too much bacteria inside the...
Yeah, so smelly farts could be colitis, a colonic infection. It could be altered bacterial flora. It could also be a disease like inflammatory bowel disease. And it is important that if somebody says smelly fart, we would first treat them with a gut antibiotic, a prebiotic, probiotic, and then we will evaluate. If this tackles the problem, end of the solution. But if it does not work, then you start evaluating them for any other sinister disease. Typically, this would mean a colonoscopy to be done to exclude diseases.
So you mentioned irritable bowel syndrome. And at this point, I have to tell you our story also. When I met you just recently, I thought I had IBS.
Okay.
And, because these are some gastric issues that I've had from time to time. And you said that, Anant, you don't need medicines, you just rest. So my first question to you, before we get into the physicality of IBS, do you think that IBS, one of the main causes is anxiety and stress?
Absolutely. So if I look at my cohort, 75% of our gastro illnesses have a functional component, psychogenic. So what am I saying here? I'm making a very loud statement here. So if I looked at patients who walked in with heartburn, reflux, pain in the abdomen, diarrhea, constipation, these symptoms, 75% of these patients had a psychogenic component, which means I had to refer them to a psychologist. If they agreed, they did go. And only 25% had a valid organic disease that needed treatment. So the psychogenic part is very common. If in the world you look at what is the commonest problem in the world, it's anxiety. It's anxiety. 3/4 of the planet population is suffering with anxiety. Either today or tomorrow or yesterday, we are all anxious. Now, why are we anxious? Maybe we are too caught up in the past, too afraid of the future, but we're not in the present. Well, that's the spiritual part of it.
I have to ask, I'm sorry, but because there's so many people I've met in the last 6 months, like medical professionals like you, and most of them told me that it has double-fold or quadruple-fold after COVID.
Yes, it has. It has. People have become more conscious about their health, but in doing so, they've also become overthinkers and they become very anxious. People have lost their relatives. People have suffered a lot in the hospital with the COVID. So they've got bad memories. And these are the patients who are definitely getting worse. But there are some patients who have actually got better. They have become far more mature. They've realized something that I call in spiritual world embrace the uncertainties. Embrace the uncertainties. When we embrace the uncertainties, we become less anxious. So those of us who have crossed the COVID and had problems, but realized, okay, uncertainty is the way of life, and we have got better. So irritable bowel syndrome patients, coming back to it because I don't want to make it too long. So irritable bowel syndrome patients are typically patients who are overthinking. They're anxious all the time. They're caught up in the past, or afraid of the future, or worried of the future, and they will have these motility issues. So there are drugs for it, obviously. There are drugs for it, something to cool them down, something to make their gut also less motile, and the diets can be changed. But most importantly, and I think all the healthcare providers would agree with me, is to first give your mind a rest. You have to take a break. You have to go somewhere, meditate, get yourself detached from your worldly life, and then get back to treating it. So the drug treatment is a secondary process in irritable bowel syndrome. The primary treatment would be meditation.
Like everyone says, oh, I have IBS problem. Like a lot of my friends use it. Is there a way to diagnose IBS?
So IBS is a diagnosis of exclusion. What does it mean? It means that if somebody comes to me and tells me I have a left lower abdominal pain, I get frequent diarrhea and I get very crampy, and then mucoid stool comes out. There's a lot of mucus in my stool, and I think I'm not able to pass the entire stool. There's still something left. I keep going back to the commode. This is typical irritable bowel syndrome. And when somebody says that to us, we would make that diagnosis, but we will never write it down till we have done a colonoscopy. And we have excluded diseases like cancer and inflammatory bowel disease. You see, you cannot be oversure or overconfident with these diagnoses. Similarly, if somebody is bleeding in stool and they are assuming it to be piles, we will never call it piles till we have done a colonoscopy. So I'm making a very large statement for the people who are hearing me here. If you have a diarrhea problem or you have a bleeding in stool problem, make sure that at least once you've had a colonoscopy, and then only you have been stamped as irritable bowel syndrome or piles.
So when you put up the camera inside the large intestine, like what do you see to check if it's IBS? Like, and just by the way, is irritable bowel syndrome and inflammatory bowel syndrome the same thing?
No. So inflammatory bowel disease is another disease. Irritable bowel syndrome is just another disease. Irritable bowel syndrome is the one which is associated with stress and anxiety. And this is the one where we need to...
That's IBS.
IBS, irritable bowel syndrome.
What we were talking about.
We were talking about. Now, when we talk about inflammatory bowel disease, there are two major subsets. You will hear ulcerative colitis or Crohn's disease. These two are brought in together in a same heading called inflammatory bowel disease. Now, this disease is more organic. Once you put in the camera inside and you see ulcers which are bleeding, proper red spots, and they are bleeding or they may have pus on them, this is inflammatory bowel disease. If it has happened more in the colon, it's called ulcerative colitis. If it happens more in the small intestine, it is called Crohn's disease. For the sake of not confusing our audience, we'll not go into the details of Crohn's and ulcerative colitis. But we definitely need to understand, what do we see in irritable bowel syndrome? So we see practically nothing. Because we see nothing that is associated with inflammatory bowel disease, we say it is irritable bowel syndrome. But there are subtle things that you can pick up. If you are a very experienced gastroenterologist who's been doing colonoscopy for years, once you put your camera inside and you find that the colon is having kinks and narrowness, if it's narrow and kinky, then we know it's irritable bowel syndrome, right? They have a lot of spasm. So that is a hallmark of what we see in irritable bowel syndrome. So nowadays we can diagnose even on colonoscopy, okay, this one is a irritable bowel syndrome. So it's very important to know this, that what are we seeing? How are you making a diagnosis? And let not somebody make a diagnosis of irritable bowel syndrome on you just because the symptoms are there. always ask for a colonoscopy.
Right. So anyone who says has IBS should go through a colonoscopy at least first.
Once.
Right. Because I really want to, there are these so many common questions that you get, like you mentioned about the headache thing, like gas causing headaches. There's also gas causing heart attacks or mimicking the symptoms of heart attack.
Yeah. Let me make a very important point again here. Gas causing a headache is something that as healthcare providers, we humor this. That a lot of patients come and say this. But frankly, patients also need to learn that they must say exactly what they are feeling rather than giving a diagnosis. For example, if you are having chest pain, you say chest pain. You don't say I'm having a heart attack. And right, as a patient, you have a right to mention your symptom, but I think it's audacious to make a diagnosis. So a lot of people will come, when I press my arm or my thighs, gas comes out of my mouth. I mean, that is a little too much to digest in a humorous way. But without being sarcastic, it's possible that everybody's got their own way of putting things. But if you want a good help from your gastroenterologist, try to state things as they really are. Having said that, let's get back to that point of gas causing chest pain. A lot of deaths happen in cardiac emergencies because the patients who land up and finally get diagnosed as heart attack but are dead in the emergency room had been treated as gas in the last 1 week or 10 days because they typically complained of bloating, nothing in the chest, but bloating and feeling nausea and vomiting. So they will go to the gastroenterologist. Why would anybody go to a cardiologist for gas and for epigastric pain? But this is typical of an inferior wall heart attack. So if the heart's inferior wall has an attack, then this is exactly what it will happen. And patients should know that the gut symptoms could mean cardiac emergency. So the gastroenterologist should also be sensitized and they should send the patient for cardiac evaluation. So that is a very common cause of deaths which can be prevented in our society. The other thing is, it's a corollary. People are very sensitized towards cardiac emergencies nowadays. I've got a chest pain, dial XXX number. We are all aware because it's written in the hoardings. But if you have an abdominal pain, do you have any number? No, you would call up your physician. You will say, I'm having an abdominal pain. It's severe. He'll say, go to the emergency or come in the evening. You will lose a lot of time. In a cardiac emergency, you're calling because in minutes I can die. But in abdominal emergency, there is absolutely no awareness in the society that people can die if they are not treated promptly. I can tell you that in this city, a lot of people die of acute gallbladder infection, acute appendicitis with perforation, with peptic ulcer perforation, typhoid perforation. And these diseases presented to them, they were having this pain and fever for let's say a week or 10 days, but they did not go to the physician or got the test done, or even if they went to the physician, they did not get the test done, or they did not do a CT scan, an ultrasound, or any blood works to confirm what they're having. They thought, okay, it's just gas, let me pop a pill. Popping a pill for abdominal pain and gas is so common that we have far more deaths due to abdominal emergencies now than anything else.
So, but then I really want to, detangle this in the sense that I want to understand what can a general consumer do when they have gas or when there is an emergency, because there are three main medicines that you will find in every household. One is Gelusil, one is Rantac, and one is Pandy. Like Pandy is what you pop up early in the morning. If someone has extreme gas, they will self-diagnose and they'll pop Pandy every morning. And Gelusil after food and Rantac probably before sleeping. That's my understanding. That every household will have.
If these tablets could be tried in the court of law, they would have been hanged.
Maybe, but I just really want to know when should these three tablets be taken by a general consumer who's watching this.
So, Anant, this has to be discretionary. It has to be good judgment. Now, that comes with education and awareness. As you know, everything boils down to good education. A society gets educated and they get aware. So now we have reached to a point where we know, okay, a chest pain means heart attack. Let's go to the cardiologist or to the emergency. But we've not yet got to the point where abdominal pain can be an emergency. Let's go to the gastro emergency. We haven't reached to that point. I think the more important question is which abdominal pain should reach and which abdominal pain can be treated at home. So let's say if I am a young person and I do not have diabetes, hypertension, and I had an abdominal pain, a gas, a bloating, I ate out and thereafter it happened. It's fair to try Rantac, Gelusil, fine, but it's not working. Then I should, in a matter of hours, or maybe by, in 12 hours or 24 hours, I should try to understand why is it not working. And I think again the same concept of warning symptoms. If there is a fever, if my abdomen is becoming tight, my belly is becoming tight, I am not able to pass a stool, or if I am vomiting, I should definitely be in a hospital emergency rather than in the house. There is more danger in asking your family physician to come home and treat me in the house than to go to the emergency, because there you would definitely get a blood test, a CT scan done.
All the infrastructure will be there.
And you would be picked up early. So I have so many friends and in the city, and I know so many who've lost their lives. Why? Because they just did not diagnose their problems early. They did not diagnose their problems early. And it was possible to do so if they had just attended the emergency and got a CT scan or got an X-ray done or got an ultrasound. And as simple as that.
I think this is very important for me to summarize, like especially for my audience, because like I had my cousin also who had bloating issues after a party, and then he was about to get married in 2 weeks. And I was in Sheffield that time. I was studying, and then he lost his life that next morning because he had those Rantac and pills and everything, but his pain continued. So, I mean, would you say a general protocol is, because he was young, he was 28, 29. So nowadays, so many heart attacks are happening at such a young age. So would you say that as a protocol for the audience, say you eat out or you have a very bad bloating issue or very bad pain in the stomach, you take your Rantac or your omeprazole or something, and then it doesn't work, within the next 2-3 hours you should go to an emergency?
Absolutely. So I'll just recount one of my friend. He was partying, and at about midnight or about 1 o'clock in the morning, he goes home. Obviously, when you partied, you have probably drank and you probably smoked, and you go home, you've eaten your meal, and he said, I'm not feeling well. And he said, I'm not feeling well, and he retires to the bedroom. And he takes the typical Gelusil or Rantac and says, I'll be fine. And the wife says, no, let's go. I don't think you're looking unwell. Let's go to them. And he said, no, I'll be fine. Just let me rest a bit. And he dies in 2 hours in the house. No treatment given, So you might ask, how would he know? And I would say, yes, how would he know? And at the same time, there could have been some warning symptoms. There could have been sweating, which somebody misses. You could have in your house, you have something called a blood pressure machine. I think almost all houses nowadays have this electronic machine. So you apply it, you can see the pulse rate and you can see the blood pressure. If your pulse rate is above 100, if your blood pressure is sky high or very low, just go to the emergency. It will take 2 minutes to know that, I'm not dealing with a simple gas. So I think this understanding has to come. It will come with education. It will come with, podcasts like this, where people are going to listen and they're going to implement this. It has to strike them. When emergencies happen, we lose our mind.
So you brought in my favorite topic, which is alcohol, because like 2 years ago, I became a teetotaler, which means I do not drink alcohol. And it really changed my life, like specifically my gut. But how do you correlate alcohol with the entire digestive system?
Okay. So you have brought up the favorite topic of mine as well, that's alcohol. You see, alcohol is a foreign body. And when I say this statement, I know I'm going to stir up a lot of controversy, but let me explain. If you're walking on the road and there's a dusty wind coming and dust go into your eyes, what are you going to do, Anant?
Wash my face.
wash your face, wash your eyes. You want the dust to come out of your eyes, right? You blink, you're not able to see at that time. You water, your eyes are going to water, and you're going to splash water in your eyes to take the dust out. And why did that happen? Because dust is a foreign body to your eye. Now, let me extrapolate that to the statement I made. Alcohol is a foreign body to us, a human body. Which means what? It means that we do not have the capacity to digest alcohol, metabolize alcohol. So when alcohol enters into a bloodstream, the entire purpose of the human body, the physiology of the human body changes. The entire focus is to excrete it out of the system. So they will metabolize it in the liver, and alcohol, its metabolite, will be excreted out, right? So what is happening is there is a lot of our effort of the liver and the kidneys to excrete the alcohol. And during this time, the other physiological processes are getting hampered. So that, remember that groggy feeling when somebody takes alcohol, or the suboptimal performance after taking alcohol. Why is that? Because the other organs are not working perfectly well. So now you imagine the same thing. Alcohol is a foreign body. As soon as you take it, the entire purpose of the body is now to excrete it out, and the other physiological processes are dampened. So during that time, our own performance is suboptimal. So that is why one should try to consume alcohol at a moderate level, even if they are consuming. And I would go on to say, there is a lot of fad about drinking. It has been glorified either in the movies or in the way people have seen it as a stress buster. But now, if you look at what is happening in the last decade, there are so many motivational speakers out there in the social media telling us about the perils and harm of falling into this, fitting into the society. This problem of fitting into the society, if I don't drink, all my friends drink and I don't drink, is a problem. If I'm 18, this is my first drink with my dad. Oh, it's a huge thing. Oh, now I have a breakup, I need to drink. I have a girlfriend, I need to drink. I get a baby, I need to drink. So this drinking thing has crept in multiple ways. And frankly, just like if we go historically, I know I'm making a longer answer to this simple question, but it's important. Smoking came in early 20th century, just before the World War I, as a stress buster for the soldiers in the war. Right. Then it went over to civilians. They said, if the soldiers can take it, so can I. Then the civilians consume it. It took almost 90 years for us human beings to put a label on that cigarette box that it is injurious to health. It's going to happen to alcohol, but it's going to take time. And we have now started writing in the movies, the subtitle is injurious to health.
But sir, I think we just live in a society where not drinking and not smoking is frowned upon. So, but we spoke about how alcohol affects the digestive system, how it's a foreign body.
Yeah.
But there's this whole new concept that I've seen coming up in the last few years, which is, the gut microbiome.
Yeah, big thing.
Then what exactly is gut microbiome?
So gut microbiome, Anant, is getting a lot of attention. We now know that there is a world, a galaxy inside our gut. Right? So when we look from a telescope, we see infinite number of stars in the sky. Similarly, when we are looking into the gut under a microscope, we are looking at an infinite number of organisms which are using our body as a cosmos. Now, there is a particular balance, a particular kind of bacteria, and they have a ratio. And if that ratio and those bacteria are maintained in the gut, that's normal health. I do not want to go into the details, it's just scientific jargon, but things like Clostridia, Bacteroid, Actinomycetes, a lot of these organisms exist in a large number.
These are different species of bacteria.
These are species of bacteria which exist out there, and they have to be in a particular ratio. We examine the stool of a normal person and you will find this ratio exists in large number of people. But when you look at people with diseases, so if you look at people with inflammatory bowel disease, somebody with small intestinal bacterial overgrowth, patients who have undergone surgery in their stomach or in the intestine, even patients with obesity. Now, that's a big thing. That's a separate talk
No,
altogether.
we'll definitely have a different podcast about it.
Yeah. So these patients will have a different gut microbiome.
Hmm.
And now that we are realizing that these patients have a different gut microbiome, we are also talking about how to correct them, rectify them, getting them back to normal. And so there are lots of talks about making capsules with normal gut flora and giving it to people who have abnormal gut flora with these diseases that I mentioned, and that can rectify their disease. So there is a huge experiment and research going on out there to tackle these diseases through gut microbiome changes. So it's an interesting area.
Just to understand, like these gut microbiome tests that have started coming up in the market, like, the Good Bug, Decode, so many brands who are doing it. Like, do you think that gut microbiome test has any value? Like, does it make sense for a person to get it done?
I think as far as research is concerned, everybody is enthusiastic. When it comes to clinical practice, we will have to see how much of this can be translated into clinical practice. Just as an example, cloning is an experimental thing, but is it there in clinical practice? It is not there. Similarly, we may have a lot of knowledge about gut microbiome, but how are we going to translate into clinical practice is something we'll have to see in the near future. I am sure that we are already doing stool examination. We typically nowadays look for Clostridia difficile organism, a bug, which if it is present in the stool signifies a bad bug in your gut. But we still do not have the necessary bandwidth to examine all the kinds of bacteria from the stool and saying, okay, this is your flora. It is done in the experimental method and research tool, but it is not there in clinical practice.
So basically what you're saying is that the gut microbiome test, right, currently is not at a stage where it can be translated into clinical medicine. I mean, it's a great thing if a person wants to know what kind of bacteria species they have, but might not be able to translate into clinical medicine as of today.
Correct.
So if someone wants to do a gut microbiome test, they can do it for their personal knowledge maybe, but it might not change a lot of things.
Absolutely right. But in the near future, I'm sure we will get there. There will be stool test, genetic tests, and lots of things.
Everything that can come.
Yeah.
So, but like just coming to a very basic, simple question for my audience, like the gut is the stomach or?
Yeah. So I should have clarified. Gut would, while I talk about gut microbiome, we are talking about small intestine. Right? But when we talk about gut in general, it is stomach is a gut. Duodenum is a gut, small intestine is a gut, colon is a gut. So when we talk about gut microbiome, we're talking typically about small intestine and large intestine. That's all we are talking about. We're not talking generally about stomach and duodenum. Out there, the gut flora is not important.
So when we talk about gut microbiome, we are largely talking about the intestine, small and large intestine.
That's right.
But the gut is ideally from your mouth to your anus.
Yes. So that's the...
Got it.
So I would also like to add here about the gut microbiome that one of the interesting clinical application of the knowledge of gut microbiome is in obesity. In patients with obesity nowadays, we can collect the stool of a patient with who is normal body weight and convert it into a capsule and give it to patients who are obese. And when they swallow it, so the aesthetic part has to be maintained. That's why it's a capsule. When they swallow it, it can change their flora and they can lose body weight. They can lose weight. So it's a very interesting thing. Again, this is in a research
like a stool transplant.
Yeah. So this is called fecal-oral transplant.
That's a technical word.
That's a technical term. But you could just say stool transplant. I'm taking the stool from one person and somebody else is taking it and they're converting it into a better gut flora, gut microbiome. So it's there.
But Dr. Baig, before I end this podcast, is there what is the one thing that you're looking forward to in the coming next 10 years in your field? Like where you feel like this is just going to change gastroenterology in terms of a technology or in terms of like a procedure, like you said?
Well, that's a very wide ball. You can hit it anywhere. But I think one of the areas that we are going to see more often is, of course, the gut microbiome. We just said that, so I'm going to repeat that. The other areas are imaging of the gut and looking at its motility. We haven't done enough research in those areas so far. We have only looked at imaging of tumors and other diseases, but we have not looked at
how the gut moves,
how it's motile, why some people feel bloated, why some people do not agree with some food. So those are the areas which will come up, and I think it will also, somewhere or the other, artificial intelligence has perpetrated almost all disciplines, and this is not going to be spared either. We will definitely be able to do tests in a simpler manner, get results faster, and a protocol and algorithm of treatment will also be made. I think many of these medicines are going to become precision medicine, which is going to work based on our genetic signature and not just as a blanket treatment, which is general for everyone. And finally, I think there's a lot of nutrition coming up in gut. We say that what we eat is what we become. And that's probably very true. And increasingly, we are realizing that some people are turning vegan, some people are avoiding roti and milk, some people are, understanding what works for them, what doesn't work for them. And nutrition is going to come in a big way. It's going to be called a personalized nutrition, and everybody is going to be evaluated by various methods, not only clinical, but also from their stool and blood. And all these signatures are going to come into play, and we will know what suits whom. Right now, as you mentioned, you had urticaria some time back. Imagine that you would just give a blood sample and a spot test, a drop of blood. And from there, somebody will say, oh, you know what, you have antibodies against brinjal. And are you consuming brinjal? And you would probably say, okay, I was. And you stop it and you're fine. So these kind of treatment is something that you could expect in the future. An additional point is about cancer screening. Cancers have increased, obesity rates have increased. These are areas of extensive research. We'll definitely get more screening tools to pick up cancers early. That's definitely going to happen. And a lot of things are going to happen with the spot test, blood test, and artificial intelligence out there is going to play a big role. As far as obesity is concerned, I think that's an area where a lot of diet and lifestyle changes has to happen. We will need to re-examine the genes and the modification that is happening over the last 50 years. Something definitely drastic is happening out there. So I think in a nutshell, those are the areas that we have to look out for. It's always going to be good to keep watching this space, because it's going to ultimately help us becoming better in our body, mind, and soul.
So the 3 points is the gut microbiome technology, AI, and better screening procedures.
Yep.
Perfect. Dr. Baig, thank you so much for this podcast and for such a brilliant conversation. I'm going to have a separate conversation with you on obesity, all the GLP medicines, and also bariatric surgery, because I'm very excited for that as well. But again, thank you so much for coming.
Thank you, Anant. It was a pleasure talking to you.